Archana Deshpande and Dr. Vashali. Now, the first case is going to be presented by Dr. B. Kanchanamala. She is an associate professor of anesthesia in the Omandurar Government Medical College in Chennai. So she's from my part of India. MBBS and MD from Chennai Medical College and DA from Stanley Medical College. Dr. B. Kanchanamala, please start.
Thank you, sir. Thank you for the introduction, sir. Good evening, everybody. Sir, I've just started sharing. Is it visible, sir?
Can you make it full screen?
Okay, sir.
No. You have to share your slide and make it full screen, please.
Just a minute, sir. I have problem sharing, sir.
We can see a screen, but I think it's doing it from a mobile.
I think
Yes,
it's
sir.
from the mobile bus.
Yes, sir.
Okay, go ahead.
I'll just try once more, sir. Is it visible now, sir?
Nope.
Is it visible now,
Okay,
sir?
Karthik, what can we do? Probably you have the Kanchanmala's,
No.
PPT. So can you share it? Or I can share it from my side also.
Thank you, sir.
Shall I share it?
Yes, sir.
Okay, I'm sharing it. So I hope it is visible.
Yes.
Okay.
Yes, sir, it's visible.
Screen.
Yeah. Please go ahead, Dr. Kanchanamala.
Kanchanamala, you just tell me next so that I'll be going to the next one. You can start now, Kanchanamala.
Sorry, sir, I just lost the connectivity. Shall I present, sir?
Yes, go ahead.
So I'm just presenting a case of back pain. The patient is a 45-year-old lady and she presented with low back pain radiating to left leg. Symptoms are present for the past 1 year. It is a dull aching pain in the low back region with sudden episodes of shooting pain radiating to left leg. There is no history of trauma, fever, drug abuse, immunosuppression, or steroid administration. Unexplained weight loss or bladder or bowel dysfunction, weakness or sensory deficit, everything is absent. What is the pain characteristics? The pain is a dull aching pain, insidious in onset. It is present for the past 1 year. Numerical rating scale is 8/10. It is progressively increasing in severity. The pain is radiating to left leg, and there is sudden episodes of shooting pain also. Pain is aggravated by walking, bending forward, and prolonged standing. It is relieved by rest, analgesics, sitting, curling up positions. There are occasional episodes of severe pain during night. Just a minute, sir.
Shall I go ahead?
Yes, sir.
You just tell me next when to go ahead.
Yes, sir. Next, sir. I'm not able to see the slides, sir.
You can't see it now?
Yes, sir. Just a minute, sir.
Can't you see slide now?
No, sir. Just a minute, sir. So there are no associated symptoms present. Am I audible, sir?
Yes, you are audible.
There are no associated symptoms like fever, bladder or bowel dysfunction, sensory or motor loss. And there are no...
So you covered the first slide. Now we are going to the next slide, second slide.
Pain, associated complaints. There are no associated complaints like fever, trauma, bowel or bladder dysfunction, sensory or motor loss. There are no red flags like progressive sensory or motor deficit, unconsciousness. Past history, there is history of several injections of analgesics along with oral drugs. There is no history of fever with rashes or vesicles or cognitive dysfunction. No history of diabetes, hypertension, CAD, epilepsy. No history of previous hospitalization. No history of drug allergy or blood transfusion. Personal history. Patient takes mixed diet. Sleep is disturbed by pain frequently. Bowel or bladder habits are normal. Treatment history. There is history of taking analgesic injections from general practitioners, and patient has not yet been investigated for pain. On clinical examination, general examination, the patient is anemic. There is no icterus, cyanosis, pleuritic edema, or lymphadenopathy. Vitals, blood pressure is 112/68, measured in the left upper limb. Pulse rate is 94 per minute. Saturation is 98% in room air and temperature is normal. On inspection, gait is normal. There are no involuntary movements, no spinal deformity or no wasting of muscles and asymmetry. On examination of back, the skin is normal. There is no swelling, deformity, scars, or sinuses, and no infection is there. No sign of infection is there. On palpation, there is tenderness over L2, L3 vertebral spaces. There is no warmth. There are no trigger points. Motor system, active movements of left hip joint. There is painful restriction of left hip flexion. Passive movements of left hip joint or when checked, left hip flexion and adduction elicited pain. Extension, abduction, lateral and medial rotation of left hip is normal. Movement of right hip joint is painless. There is no restriction of movements. On motor examination of the left and right knee joint is normal. Range of movements is normal. Ankle movements are also normal. Sensory system, hyperasthesia is elicited over the posterior aspect of thigh on light touch. Vibration, proprioception, tactile localization are normal on both sides. Reflexes, deep tendon reflexes, knee jerk exaggerated on the left side. Right side knee jerk is normal. Ankle jerk is normal on both sides. Superficial reflexes, Babinski is negative on both sides. Special test, SLR, straight leg raise straight test is positive on the left side and Stoops test is negative on both sides. Investigations, complete hemogram, hemoglobin was 8 grams per deciliter, CRP was 10, ESR is 20 millimeters per hour. Liver function test, renal function test, serum uric acid and serum calcium are normal. So diagnosis. Thank you, sir.
So what was the upper limit of the CRP? CRP 10 you have told, because in laboratory to laboratory it varies, the ranges varies.
Upper limit was 6, sir.
Okay, fine.
Okay, so we have a 45-year-old lady with a history of lower back pain radiating to the left leg. So she has left the lumbar radiculopathy for a duration of 1 year. And there doesn't seems to be any numbness or motor weakness. 45-year-old left leg pain. The history suggests of hyperesthesia in the left posterior thigh, and some of the deep tendon reflexes seems to be exaggerated on the left side. So 45-year-old lady, 1 year history, lower back pain radiating to the left leg. Right. So having got this history, can I invite Dr. Jeshnu? Dr. Jeshnu, are you there? So in terms, yeah. So in terms of provisional diagnosis, what do you think we should keep in mind with this history that she is presenting?
Okay. So primarily, this is the she is presenting with low back pain and radiating to left lower limb. But on examination, she had painful hip movements, primarily hip flexion and hip adduction. So,
okay.
Am I audible?
Okay, yeah, go ahead, Jeshnu.
And on the examination, she had knee jerk aggravated. So this is more like it's not a very straightforward diagnosis, and she has some sensory issues on backside of the thigh. So particularly, this is not pertaining to a typical dermatome. If she has exaggerated knee jerk, that should be L4 dermatome. If she had posterior thigh, that is indicating towards more of L5, more of S1 dermatome, and her hip flexion is painful. That is more towards that flexus of the hip might be at some strength, and as well as adduction is also at painful flexion and adduction. So piriformis might be at the fault. So it's a kind of mixed diagnosis, but for the sake of differential diagnosis, it can be lateral canal stenosis, it can be myofascial pain syndrome affecting iliopsoas, iliacus psoas, or both the iliopsoas. It can be piriformis also.
Right. So what Jeshnu is essentially saying is this is probably disc herniation. It could be a pathology coming from the left hip joint, and the other possibilities being piriformis syndrome and Myofascial pain. Myofascial pain. So you told 4 points, right? So, right. So, can I ask Dr. Jadan here? Jadan sir, did you hear to the history? You are muted.
Yeah. I heard history. I read it also. It was very complex presentation, in fact, very difficult to pinpoint. Yeah, you can ask your question, Dr. Karthik.
So, Jesnu has put up 4 provisional diagnoses. He's talked about disc herniation. He talked about piriformis syndrome. He's talked about primary pathology coming from the hip joint and myofascial pain. In terms of diagnosis, do you concur or you want to add something else in terms of differential diagnosis?
Yes. Two possible inclusions could be that pain might have been arising either from the disc, which is higher at L2 or L3 level, one of the probability, or it can also be a SI joint indirectly, SI joint inflammation, which might be causing the pain in the or paresthesia in the posterior thigh. Along that, I think he has covered myofascial syndromes that could also be a cause in this patient. So this is my presumption in this to add on. It could be a disc or it could be a SI joint also along with the piriformis and the hip pathology.
Right.
I think we have not included the facets, but particularly one condition in facet when there is a cyst or inflammation could also result in such syndrome where the paresthesia as well as the occasional shooting pain due to direct compression over the nerve or the nerve roots.
Right. So, thank you, sir. So, essentially, Jadan sir has added 2 more to the provisional diagnosis. So, we had an original list of 4. Now, Jadan sir has added sacroiliac joint arthropathy and facetal cyst, which anteriorly may compress the nerve root that can cause radiating pain. Now, can I invite Dr. Varshali here and ask her? We have, ma'am, 6 provisional diagnoses at this point of time. What do you think is the most likely in terms of provisional diagnosis? And do you want to add something else in terms of differential diagnosis?
To add something more, I would like to know the profession. Is she a housewife or he has any profession who is long standing or prolonged sitting? That is one thing in the history I would like to know more. And second thing is she said that the pain gets to the legs also, but is it mid leg or till the toes? And is it a dermatomal or radiculopathy type of pain or a complete leg pain? So that I want to know, is she able to sit down or squatting or cross leg if she is able to sit? So that part in the history I would like to know. Yeah, and in provisional diagnosis,
we'll let Dr. Kanchanamala answer those questions.
Yeah.
Good evening, madam. Madam, she's a tailor by occupation, and she's a tailor by occupation, and she has got the shooting pain, and it is radiating only up to the knee, back part,
Right.
back of thigh, extending up to the posterior aspect of knee.
Okay. Yeah. And in the special tests, you have mentioned only SLR and Stoop test, which is negative. SLR is positive. At what degree it is positive? And what about the other tests like facet loading test or Faber test?
Other tests were negative, madam.
And other tests for SI joint?
Other tests for SI joint are also negative only. SLR only was positive, madam.
Yeah, SLR at the degree?
40 degree.
Okay. And reverse SLR?
No, madam, it was negative.
Okay. And while doing SLR, does she had any tenderness or tightness at the back of the thigh or back of the knee?
Yes, ma'am. She had mild, she said she was feeling tightness at the back
Hamstring
of
tightness.
thigh. Yes, tightness at the back of thigh.
Okay. And did she have any tenderness at the SI joint on palpation?
On palpation, there was tenderness, ma'am. Tenderness at L2, L3 level.
Okay, and
middle.
SI joint?
SI joint, she had only dull pain. Tenderness was elicited
Okay,
at
okay.
L2, L3 level.
Okay, so what I think it's a mixed picture. Maybe since it's a long-standing pain of 1 year, the pain might have started with something and now it has covered, spread or referred pain to other structures. So I would like to have provisional pinpointing towards the SI and maybe hip also, and then converting to myofascial.
Okay. But SLR is positive.
SLR is positive. That's the reason SLR, if it is giving radicular pain, then it might be root compression.
SLR is
but if
producing radicular pain here, correct?
Dr. Kanchan,
Sort of pain. Sort of.
SLR is producing leg pain is what you had written.
Yes, ma'am. Yes, sir. But it is a type of shooting pain or compressing pain. She's not able to pinpoint. But
SLR is producing leg pain and Faber is negative.
Yes, sir.
Right. But then
There was
SLR
just
for...
it was not eliciting pain. Faber was just tightness was there. She was not able to move. But there was no pain actually.
Yeah, but it's not typical SLR also positive to pinpoint as an SLR will be positive in the lower lumbar. For L1, L2 disc, whether she has tenderness, it should be reverse SLR positive or the fly test positive. So it's a confusing.
Posterior thigh pain, SLR positive. Pain increases more on flexion. Sewing suggests
Maybe
of,
this.
we'll go about it. We'll discuss further. Right. Can I invite Dr. Matthew Tong here and ask him, sir, you've heard the history. Is there anything else that is possible in terms of differential diagnosis?
In the diagnosis, I'm quite impressed by the history of a pain at night. Patient is anemic. Is that correct?
Yes,
the
sir.
patient has elevated ESR and CRP.
Yes.
And the extension from L2 down to the hip suggests maybe a paraspinal involving and entering the spine through one of the foramen, causing radiculopathy. And could it be some form of did you all do a pelvic examination or not?
No, sir. I didn't do so.
Oh, okay. All right. One of an MRI may be helpful to elicit maybe an abscess of some sort. You know, I don't know. I haven't much experience. I don't know if in TB or whatever is the ESR that this kind of range, or should it be much higher than this? I'm not very sure. But there's a long segment. I would think of something like that. Okay, that's what I can add. Thank you. Over back to you.
So I think Dr. Matthew Tong is talking about something like an iliopsoas abscess that can cause a similar pattern, but the ESR is only 20, which is just about borderline, and CRP is 10. So probably that is not suggestive of the value is not high enough to suggest a systemic inflammation or a severe infection, and there was also no history of any fever. So 1 year history, probably not iliopsoas abscess. Can I call in Dr. Joyshri here and ask her? We talked about 5 or 6 differential diagnosis, ma'am. What do you think is happening, Dr. Joyshri?
I would agree with Dr. Tang that it's probably something like either a disc or a lateral recess, which is causing a foraminal narrowing and radiating pain. But because of her profession, you cannot rule out something in the hip or around the SI joint. That's why I asked what kind of sewing machine. Is it a tabletop or a foot sewing machine? If she is using the foot pedal all the time, chance of localized inflammation cannot be ruled out, or something in her SI or hip. I didn't see her mention any weight loss or...
There's no weight loss.
There's no weight loss, but the CRP is raised. So cannot rule out, we will considering that she comes from India, you cannot always say it cannot be a TB abscess. Over to you.
Right. Okay. For the sake of the juniors, can I ask Dr. Jeshnu to explain to them how you will properly do a straight leg raising test and how do you interpret the results?
First, we'll put the patient in supine position, and first I'll go for the unaffected leg to see if cross leg SLR is positive, because that is more indicative of the pathology. And I'll putting the hip and knee in a natural position, that is in neutral position, and then I'll be going for passive hip flexion with knee extended and increasing up to up to 70 to 80 degree, not more than that. And if patient is having reproduction of that radiating pain at around 40 degree to 70 degree, then that might be more suggestive of as a positive SLR. And once I'm done with the contralateral side, then I will move towards the affected side and repeat the procedure.
Right. So if this patient, for the sake of the juniors, just know, if this patient has exaggerated back pain on SLR, what does that mean? Would you infer something from that?
That can exaggerated back pain, but not the leg pain. That can be suggestive of facet, or that can be suggestive of myofascial both.
Right. Some take-home point for the juniors is whenever you do an SLR, there are two types. You can obviously do this in sitting and in supine. When the patient does it themselves, it's called active. When the doctor does it, it's passive. And one of the things that you want to do is, first thing is, he said, do in the normal, the less affected side first. And if this patient, when let's say this patient is having left-sided radiculopathy, if you do a right side SLR, and if this patient is having, when you raise the right leg, this patient is having pain in the left leg, that's a crossed SLR positive, and the specificity of crossed SLR is much more than the normal SLR. So that means definitely there's a disc herniation. Now, one thing that you want to keep in mind is when you do in the affected side, most important thing is you need to have pain in the legs. So the pain has to be in the legs at a degree of less than 60 degrees. So most people will have pain beyond 60 degrees. So if you're having pain beyond 60 degrees, that's normal. So that doesn't count. So if these patients are having pain at less than 60 degrees and pain in the leg, that is in the buttock, posterior thigh, or
Karthik, I wish to add on another thing, not mandatory, but it is desirable, that when you are raising the one leg, the other leg should be little bit, knee should be little flexed. Knee and hip both should be flexed. And then we should be raising. Whatever leg you are raising, the other leg, the knee should be extended, hip we are flexing. The other side, the knee and hip should be flexed.
Straight, yeah, straight. See, the side in which you are doing has to be, the knee has to be straight. That's why it's a straight leg raising.
So one more point I would like to add. While if you are going for SLR and patient is complaining of leg pain, it might not be always radiculopathy. It should be it should be in a dermatomal pattern, and you should also rule out the tightness of the muscles, especially calf and hamstrings. So if it is more of a patchy or global thing, it can be instead of canal stenosis, it can be due to myofascial again.
Right. Yeah, point taken, Jason. Thank you. Can I ask Dr. Jadan, sir, to explain, for the sake of the junior, sir, what are the pains that may aggravate in terms of back pain on flexion, and which are the pains that may aggravate on extension? Just for the sake of the junior, sir.
Yeah. For flexion, the pain which is aggravated possibly comes from the disc. That is one reason, or any sort of thing which is causing stretching of the sciatic nerve can also be presented in the flexion. Also, pain coming from the psoas compartment also aggravated. It is relieved during flexion and exaggerated during extension. Pain arising from the facetal components other than the actual compression over the nerve. Suppose there is a cyst, that pain will be aggravated on flexion. But if it is the facetal joint, facetal arthropathy, and that pain can be increased on the loading of the facets or on extensions. So that's where we differentiate that if pain is, suppose myofascial, I take one compartment, the myofascial pain. When it is flexion increases the pain, it is the quadratus lumborum pain. When it is increased on extension, it is the psoas pain, which is relieved on the flexion. So that's how we differentiate in the muscle compartment. The flexion increases the pain if the disc is involved or nerve is compressed, and it is exaggerated when the facetal arthropathy is there. When the facets are loaded, they causes the pain during the extension. So that's how we differentiate between facetal, disc, and the myofascial pains.
Thank you, sir. Can I ask Das, sir, what are the pains that become worse on flexion and extension?
So Dr. Jordan already told all these things. So what additionally we can do that whether the pain is in the midline or in the paramedian area. Midline, what Dr. Jordan told, if it is because of the disc, flexion will be increasing it. Another one, two I should add. One is if it is a vertebral body component. Means because what you need to remember is what are the structures which are there anteriorly which might be compressed on the flexion. So the midline structures are, one is disc, another is your, suppose there is a discitis, if there is a internal disc disruption, if there is a vertebral body compression fracture or a vertebral body metastasis. So there the midline structures which will be compressed on the flexion, so pain will be increased. And another structures which why the pain might be increased is your interspinous ligament sprain or the encephalopathies. So then it will be stretched and the pain might be aggravated. The difference between these two is interspinous ligament structure is very superficial. So here the pain will be very pinpoint. The patient will be flowing and you'll be getting the local tenderness. Whereas the anterior structures like the disc, the vertebral body, you cannot palpate them and this pain will be diffuse because it is a deeper structures, it is innervated by the sympathetic fibers. So these are the midline structures. Now extension on the midline structures is, the two things should be kept in the mind. One is if it is a bilateral facet joint, then patient might be presented with the midline. Otherwise, patient normally presents the paramedian pain. And if it is a canal stenosis patient also, when you are asking the patient to do the extension, the patients have a feel of the back pain as well as patient will be reproduction of the, the claudication kind of leg pain also will be reproduced on the extension. So these are the two midline pathology which might be pain will be extensive. Paramedian, what Dr. Jordan nicely explained, that anteriorly we are having the flexion. So the paramedian structure, when you are doing the flexion, if it is a psoas is anterior to the neurovascular bundle. So psoas flexion pain will be relieved, whereas quadratus just posterior to the neurovascular bundle. So flexion will be increasing the pain. Whereas if you are doing the extension, the psoas will be stretched and the psoas myofascial pain will be aggravated on that. So these are the more or less, the structures. The midline structures in the midline and the structures in the paramedian area. Paramedian area mostly it is the myofascial component. The psoas and quadratus we are most commonly the talking about just because it is forming the anterior and the posterior boundary of the lumbar plexus.
Right, sir. Thank you. Can I invite Dr. Varshali here and ask her? This patient is having radiating pain in the posterior side. What is pseudosciatica? What are the causes that cause pseudosciatica? And is this patient having possibility of pseudosciatica?
Yeah, pseudosciatica is pain which mimics like pain in the sciatic dermatome. And it is not basically because of the compression of the nerve at the center or at the disc level, but along its course anywhere. So it could be paraspinally or mainly at the piriformis muscle, where any tenderness or any piriformis tightening may cause compression because it just lies anterior to the piriformis. So pressure over the sciatic nerve at that level may mimic the pain same as originating from the sciatic coming from the central or the disc pathology. So that is pseudosciatica.
So you're saying potentially this could also be a piriformis, which could be a pseudokaryotic. Right. Jeshnu, can I ask you, from the history, first thing as a physician, when you examine patients with back pain, the first thing that you're worried about is these patients are having any red flags, right? So you know what we as a physician, what do we keep in mind when we say red flags in back pain? What are the red flags in back pain, and is this patient having any of those red flags in the back pain examination? Dr. Jeshnu.
Red flag can be history of trauma, then acute presentation of the symptoms, or acute exaggeration of the long-standing symptoms. Then impaired bowel and bladder habits can be there. Weight loss over the last couple of weeks can be there, or low-grade fever can be a red flag, and severe motor impairment for the lower limb is another red flag. These are the some importance which I can think of. And
so what Jeshnu is essentially saying is any possibility of trauma, any possibility of any tumor, any possibility of any infection, or progressive neurological deficit is something that we should keep in mind before we jump in and go for a less serious diagnosis. So if there is a red flag, you should get an urgent imaging, and if required, get a consult from a spine surgeon or a neurosurgeon if you think it is mandatory. Right. Can I call in Dr. Matthew Tong here and ask him, what is his opinion about Coda Equina, and is there a possibility that our patient here is having any feature suggestive of a Coda Equina?
Oh. Coda equina tries usually is resultant on a central lesion which catches nerve roots on two sides of the thecal sac. Something which catches on one side usually will not result in Coda equina because the bladder and bowel are bilaterally innervated, you see. But the thing is, that's not to say that it can never happen, because something can evolve. You see, a lesion can evolve from a unilateral into a central lesion if it gets bigger, or is it organic or a mitotic lesion of some sort. It can evolve. You see. In this case, it has already gone on for 1 year. The hemoglobin is a bit low, but the thing is, patient has not changed much in terms of symptomatology. So Coda equina has not happened yet, I think.
Right. Okay.
Thank you.
Thank you.
Yeah, Karthik, can I add another one thing here? That the knee jerk on the affected side is exaggerated. So Coda equina syndrome is always the lower motor. Coda equina means lower motor. So Coda equina syndrome, the knee jerk cannot be exaggerated. So that itself, rules out the possibility of the Coda equina. Another thing very interesting, this is why the knee jerk is exaggerated on the affected side. So what is my, looking at the case scenario, what is my opinion is, only one pathology cannot explain the whole scenario. And first of all, the exaggerated knee jerk can be sometimes the knee jerk can be brisk in a normal person. So maybe this is an observational, the observational fallacy, I should say, that exaggerated brisk knee jerk has been interpreted as the exaggerated jerk. Otherwise, when the Babinski is negative, muscle tone has not been increased or other features are not there, only isolated knee jerk exaggerations may not be a feature of the upper motor neuron lesion, maybe just a the brisk knee jerk which has been interpreted as an exaggerated knee jerk. This is my opinion. Others can. Dr. Tung, what is your opinion? This exaggerated knee jerk.
Oh, Exaggerated knee jerk is the efferent pathway is from the quadriceps is L2, 3, 4, and at the same time when it is a monosynaptic reflex, but at the same time an interneuron must message the quadriceps to tell the quadriceps, the antagonistic muscle, to relax. Sometimes with the quadriceps is when the hamstrings, sorry, at the same time, interneuron must inform the hamstrings to relax. If the hamstrings are weak, then it sometimes manifests as an exaggerated knee jerk. That is, and it can still go for a any kind of lumbar radiculopathy. Thanks.
That means here the upper motor neuron lesion above level, because it is not matching with the whatever the other things is there. My observation regarding in this case scenario, though Karthik has not asked me about my opinion, but still what I was feeling that the whole scenario is complex and only one pathology is difficult to explain everything in a very nice way. Though this is the reality. In reality, we always get this kind of scenario where it is not exactly fitting with any of the diagnosis. So here, looking about the observations, night pain, what Dr. Matthew was telling, night pain, the CRP is increased. So a little bit of tenderness over the SI joint, paramedian side, inability to flex the knee joint. So all these things, one thing has not been discussed, what I was thinking, that it can be a spondyloarthropathy patients as well. So spondyloarthropathy, why I'm talking that multiple areas, multiple joints are involved in the spondyloarthropathy, hip, the facet joint, the sacroiliac joint, all can be involved, and there might be associated these things associated the facetal cyst or swelling, which might be impinging some of the nerve roots, and there might be associated myofascial pain. So altogether can give rise to this kind of picture. So I'll be asking, this, if in these cases definitely MRI is needed, but I'll be focusing more on the sacroiliac joint and the hip joint to rule out this possibility of the spondyloarthropathy.
Right. Thank you, sir. So in terms of provisional diagnosis, what our experts feel is we have got about 6 or 7 of them. So obviously, a lot of people feel that this could be a disc herniation with the nerve impingement with radiating pain in the left leg. We discussed briefly about sacroiliac joint arthropathy. The things not going in favor of sacroiliac joint arthropathy is the favor seems to be negative. And there doesn't seem to be any posterior superior iliac spine tenderness. We talked about pyriformis syndrome. Spondyloarthropathy is an provisional diagnosis that we should keep in mind, but the ESR, the inflammatory markers, are not too strong in terms of spondyloarthropathy.
No, sometimes ESR means the markers may not be positive in all the cases of spondyloarthropathy, and one single test negative cannot rule out. I'm not talking about this is spondyloarthropathy. Yes. Other possibility can be a prolapse disc associated muscle spasm. That can be also a possibility. So, but I am talking about because spondyloarthropathy was not included in the differential diagnosis. That's why I wanted to add it.
Agreed, sir.
May I add one thing? Sir.
Yeah.
Regarding the myofascial pain, though we have differentiated, like in presentation, what will be in the quadratus and in the psoas. But as her profession goes, she is doing a stitching or tailoring job. And the low CRP could be increased CRP, not to that level showing the absolute inflammatory process, but repeated injuries like myofascial, the muscle injuries, which
yes, definitely that is a very strong possibility, because the profession related this myofascial pain is definitely one of the important.
And as far as the night pain concerned, this is also seen where the patient is relaxed in the bed. Because these contracting muscles like psoas and the quadratus lumborum can also cause the pain in the night time when there is difficulty in the turning in the bed, particularly in quadratus lumborum patients. So this could be one of the presentation in the myofascial syndrome also.
Right.
And
yeah, go.
And she's also having pain in the back. Those classical triggers have not been described in the history, but feeling the pain along the muscle points, which are mostly shown as the triggers in those area of quadratus lumborum or the psoas muscles, could have been raised, and also seeing the deep pain in the piriformis fossa would have helped to clinch the involvement of the piriformis muscle. And also at times, inspection is very important when the patient is light prone and both the piriformis areas are exposed. The spasm of the affected side, sometimes seen as a very important landmark swollen piriformis, though it is a deep muscle, but can be seen in the lean thin patient, though in a female it is difficult to say. But few lean thin patient, male patients, I have seen that a prominent piriformis in the spasmic state. So that just want to add in the clinical examination.
Right. Can I call in Dr. Joyshri here and ask her how do you clinch the diagnosis now that we have about 8 or 9 differential diagnoses?
I think, the easiest thing right now is if you have an ultrasound machine in your office, pull it, examine her hip, you'll get an idea about her SI joint. I also thought that you cannot rule out bursitis, especially with her profession. So all the local stuff you can see. You can also put your probe around L2, L3 and see if there is something in the soft tissue. Then you can decide if you want to do X-ray or MRI.
Right. So thank you, ma'am. So ultrasound examination in your clinic is going to give you some help in ruling out a few of these differential diagnoses. Now, can I call in Dr. Kanchan and ask her, how did she investigate further and what were the findings of the investigation?
The patient is not affordable, sir. So I could not do MRI. So just a preliminary X-ray, which was not much revealing.
Right. Okay. So without an MRI,
at least you should have an ultrasonography, as Dr. Jasri Madam told.
Probably I'll be following her up, sir. Planning to take her to my hospital.
Some differential diagnosis you can rule out. Not all.
Sometime in X-ray, also, the spasm of the affected side of the muscle also changes in the curvature of the spine. Sometimes it is notified. I don't know whether it is reported in this time or not. Though it may be not a very significant finding, but sometimes because of the continuous pain, there is a spasm in the psoas and the quadratus side, and the spine shows the scoliosis on that side.
See, one of the other things, if you're getting an X-ray, you can do, if you can't get MRI, is do a flexion extension X-ray. Okay. So at least you will see what's happening to the disc height, if there is any mobility, and you can see your facets. It may be of more help than just getting a plain AP lateral.
Thank you, ma'am.
Okay, so probably given that we have all of these differential diagnoses that have been thrown in, further investigation probably, since this patient is not having any of the red flags, should include X-rays. We need to do, if possible, bedside ultrasound to rule out some of these differential diagnoses. And probably considering this patient may not go for the MRI, I think we can safely treat her conservatively with the available information that we have. So the investigations that may have been interesting or that may have given us more information include, other than the X-ray, which is the flexion extension X-ray, A 1-year-old disc herniation or a disc pathology may have shown us some reduction in disc height, may have shown degenerative changes in the disc level, osteophytes and stuff. So that must have given us some information. Ultrasound would have given us some information. There is also a role for nerve conduction studies. So nerve conduction studies show typically L5 or an S1 radiculopathy. That would have given us an information. The X-ray would have helped us, other than to reduce the disc height, may have given us some information to see if these patients had any sclerotic changes or degenerative changes in the sacroiliac joint itself. So maybe preliminary sacroiliitis, considering there is no rise in the inflammatory markers, the X-ray may have given us a clue about the sacroiliac joint and also about the left side hip joint. So obvious hip pathologies you may be able to pick up from the X-ray. The gold standard investigation would have been the MRI, which would have clinched the diagnosis and may have given us a clue as to how to proceed further. Now that we don't have an MRI in this patient, other than treating these patients conservatively, we can't go ahead. So I wouldn't recommend doing any type of intervention without having the appropriate investigation. So at this point of time, with the available information and the examination findings, probably it's acceptable to all that we can go ahead and treat this patient conservatively initially and see how it goes. And if she doesn't respond to conservative treatment, which includes some lifestyle changes, basic medication, if she doesn't come around, maybe at a later date, think about investigating her further. So not recommended to go ahead with any type of interventional pain procedure without the appropriate investigation.
Dr. Karthik, one last thing I just would like to add, which somehow is missed, is the Bertolotti's syndrome, which also present in the same way as the patient is having complaints, because it is can be present as the acute or the active sacroiliitis, or also can be present as the compression on the sciatic nerve. It also present low backache continuously, like disc, most of the time protruded disc presenting. So it is a very complex presentation in Bertolotti's, depending upon which site, what activity, what is the state of the joint, that very movement can present. And also active, when the pseudoarthrosis is happening, CRP can be raised for time being. So Bertolotti's also fitting in it, but that can be cleansed on a X-ray, possibly if it is not reported.
Right, so point taken. So transitional vertebra Bertolotti syndrome, spatulated L5 transverse process articulating with the sacrum can cause the lower back pain. Anything else any of the other experts would like to add in terms of differential diagnosis or in terms of management? Please let me know. And any of the audience would like to contribute anything in terms of doubts regarding this case or anything else you would like to contribute, please put it in the chat box. The things that have been, other things that have been coming in the chat box include interspinous ligament. So interspinous ligament can cause midline back pain. Ischial bursitis is something that can cause gluteal pain, especially for somebody who has a history of sitting for a long duration. So that's something that we need to consider. Transitional vertebra Bertolotti syndrome is a possibility, yes. Anything else any of the experts would like to contribute in this case? Is there any other difference of opinion in terms of management?
So I fully agree with your view that interventions, either interventional pain management or surgical interventions, cannot be done because the MRI is not there. And another thing, at this point of time, apart from mildly elevated CRP and a little bit of anemia, we don't have any other features which are pointing towards the red flags. So if because the red flags are not there, So the conservative management can be done. And if not responding, then definitely we have to have some MRI before going to the further management.
Right. So thank you very much. Can I invite Dr. Kanchan? Thank you, Dr. Kanchanamala.
Thank you, sir.
Thank you, Dr. Kanchanamala. Nice presentation
Thank
of
you,
your
sir.
case.
Thank you, sir.
So thank you, Dr. Kanchan Mala and Dr. Karthik. So let me introduce our second speaker for today. He is a very humble, I should say, very sincere, dedicated one-year fellow who is presently doing his fellowship at Dardia. He is a consultant anesthesiologist at National Trauma Center, Kathmandu. He has done an observership in neurology from Harvard University. And he will be just sharing again another case on low back pain. So I wholeheartedly welcome you, Dr. Tritha, for your presentation. Kindly share your slides. Dr. Tritha, are you there?
Yes, ma'am, I'm here. Thank you, ma'am.
Dr. Tritha, we are able to see your slides. Yes. Yes, please go ahead.
Good evening, everybody. Today I am going to present a case presentation. And in case presentation, 3 complaint, 37-year male presented to our hospital with 3 complaint of low back pain since 1 year, and which was gradual onset and aching type, mainly on left paramedial with radiation to left hip and anterior thigh and flank of the left side, and difficult to wake up from the bed. It was moderate to severe in intensity, and it was continuous in nature, and aggravates on prolonged sitting to standing, turning on bed, and forward flexion and climbing upstairs, and get relieved by lying down position and extension of back and taking analgesics, and occasional history of radiation to left lower limb, which was tingling type and electric shock nature, and also pulling type sometimes. And there was no history of recent trauma, no history of morning stiffness, multiple joint involvement and skin changes, no history of fever, rest pain and night pain, no history of weight loss, no history of breathing difficulty and altered bowel and bladder habit, no history of recent viral infection like COVID-19, and no history of redness of eyes, no history suggestive of other system involvement, and no surgical history and trauma in the past. And in past history, left was S1 selective nerve block was done 6 months back, followed by pain relief of 1.5 months. And occupation-wise, he was farmer, and family history was non-significant. And on examination, patient was conscious, cooperative, and well-oriented to time, place, and person. Gait, it was slightly tilted gait to opposite side of the pain, and body habitus moderately built and nourished, and higher mental function was intact. Inspection of the back and lower limb, skin over the back and lower limb was normal, with slight scoliosis with convexity on left, muscle wasting was absent. On palpation, midline tenderness was present between L3 and L4 spinous process also, but there was tenderness on left paramedial side over the patatus lumborum muscle area, and which was thought band feel like, and there was presence of the jump sign. And lower facet, lower lumbar facet non-tender on left side, right side, and left side cannot perform because of the pain. Bilateral SI joint was non-tender, and piriformis bilateral was non-tender. Range of motion of back, flexion was painful, extension was normal, lateral bending was also painful, and rotation also painful. Sensory and motor examination, no any sensory and motor deficit on both lower limb. Motor examination, no any rigidity and spasticity, and on hip, all motion flexion, extension, adduction, and abduction was non-painful, and power was in all range of motion. It was 5/5, and bilateral knee flexion also 5/5, extension also 5/5, and both dorsiflexion and plantarflexion of ankle and great toe was 5/5. Deep tendon reflexes, knee reflex was normal, ankle reflex was normal, Babinski sign was downgoing on both lower limb, and absence of ankle and knee colonus. Special test, myofascial tender point jump sign was present on left quadratus lumborum area in paramedial area, bilateral favor and fear normal, negative, facet loading test was negative, and sacral thrust test was also negative, and bilateral straight leg raising test was also negative. Cardiovascular examination was normal, respiratory examination was also normal. On investigation, complete blood count was within normal limit. ESR and CRP was also on normal limit. On NCB EMG report, there was a feature suggestive of left S1 radiculopathy, and MRI, no any significant finding was there. That is the diagnosis.
So thank you, Dr. Tritha. You can stop sharing your screen. Press on that stop the share option. Okay, thank you so much. So first, how are we going to discuss this case is, first we will be emphasizing on just the history. And then the second step, we will be going to the clinical examination, because this is how we have been seeing in our day-to-day OPD practice. We just take a history, we listen to the history, and then we go to the examination and we try to, confirm whatever we have thought of. So this is how we are going to proceed today. So let me summarize only the history I'm taking. We are not going to the clinical examination right now. So with that history itself, let us formulate some kind of, diagnosis, provisional diagnosis, differential diagnosis, and then we'll be confirming them with our examination. Fine. So let me summarize. He is a 37-year-old farmer. So what Dr. Vashali was telling just a few minutes back, that occupation, yes, it is very, very important. Fine. So he's 37-year-old. He's farmer by occupation. He is having low back pain for the last 1 year. Now this pain, we will go with the mnemonic, which we have been, teaching in our pain courses. Our mnemonic to take the pain history is Ola Car Night Ride. If you'll remember this mnemonic, it'll be very easy for all those people who are very new to pain medicine to just take the pain history, where your O is for the onset of pain, right? LA is for the location of the pain. C is for the character of the pain. A is the aggravating factor. R is the relieving factor. Night is for the night pain. And ride is for the radiation of the pain. So if you have been riding into Ola, then this mnemonic is really going to be very helpful for you to take the history. Fine. So now he is having pain for the last 1 year. And this pain is of, if we go by the onset, so we can say it's gradual in onset, right? Then we'll be going to the location. So it is paramedian in location. So I would go to Dr. Jeshnu. Dr. Jeshnu, could you please help us in just summarizing some of the pain generators which present as, paramedian pain, which sir has already discussed though. So let us revise them once again. So Jeshnu, are you there?
Yes.
Okay.
So, he's having pain left paramedian, which aggravates on sitting.
No, we are not going into that. You just tell me what are the causes of paramedian pain. Just.
Okay, for paramedian pain, it can be myofascial. Sorry.
Yes, one.
It can be myofascial. It can be facet joint.
Yes.
Myofascial, it can be more commonly QL or iliacus.
Okay.
It can be a facet joint. It can be a sacroiliac joint.
Okay. So what Dr. Jeshnu wants to say that you can have a pain generator from the facet, you can have a pain generator from the SI, or you can have a pain generator from the myofascial, from the paraspinal muscles. Our core muscles, they can act as a pain generator, and they can present their pain as a paramedian pain. This is what Dr. Jeshnu was trying to convey us. Fine. Okay. So now the second is location. Then it is the aggravating factor. Now he says that his pain is getting aggravated when he is sitting for a long time, or when he is sitting to standing, when he is just in the sitting posture, and when he's trying to stand up. So that is also that is also very painful. And then when he's turning on, like suppose it's lying down in the supine position on the bed, and when he's trying to take a sidewise, that is causing him pain. And of course, he's finding it, forward flexion is also painful, and so is the climbing up the staircase. So I'll go back to Dr. Ravi, and I will show, Dr. Ravi, could you please help us, and could you please tell us what are the causes, what are the pain generators which really gets aggravated, the structures which causes pain, and that pain is getting aggravated on sitting. So could you please enumerate 1 or 2 causes for that?
Yeah, good evening, ma'am. Thank you. So right now, from the history, the one-sided pain and the pain which is getting aggravated on sitting. So the most probable diagnosis here might be the first SI joint, then the myofascial syndrome, including the QL part, especially the QL quadratus lumborum myofascial pain syndrome, that is quite aggravated with sitting. Thirdly, if we talk about this, the rare diagnosis, which differential diagnosis, which Jordan sir was talking, the Bartoleti syndrome. Yes, it also gets aggravated while sitting. So 3 things which I will say that which is getting aggravated on sitting, these pains.
Okay, so pain which is getting aggravated on sitting.
I used to add another thing, which is not again more common. It presents with more of axial pain, is your discogenic. Discogenic pain mostly presents with the midline axial pain, but sometimes, in some cases, it can be the unilateral, one side, and it can be aggravated on sitting, but it is not the common presentation. Common presentation is axial pain, midline pain.
So pain which is getting aggravated on sitting, as Dr. Ravi said, is your SI, right? And then we should think of a myofascial pain, and what sir has added on, but that presentation is going to be axial. So that is 3 things. Fine. Then coming to the relieving factors, he said that his pain gets relieved when he is just acquiring a lying down position. So whenever you want to take a history and you want to ask, like patient is telling you that, when my pain is getting relieved when I'm lying down, do ask what exactly is the position in which, in the lying down, he is getting relief, because the presentations of the pain, he will be different, and those patients will be acquiring a typical position in order to get rid of it. What Dr. Jadun sir was telling you, right? So I will now go to Dr. Varsha, if she's there. Dr. Varsha. Okay.
She was not able to join.
Okay. So Ashok sir, could you please tell us what are the positions, when I'm lying down, I'll be acquiring if I am having pain in some of my structures?
Yes, like if you are having pain related to facetal joint, particularly, the extension causes pain. So people used to curl up in the bed, actually. And similarly, the patient affected by the myofascial pains, they are very afraid of turning in the bed, whether it is a QL or even the SOS. They try to be still in the bed because the movement causing some sort of loading in the muscles, and they increase the pain. So these 2 conditions, particularly coming to my mind, that particularly QL patient, also SI joint patients often complain of pain while they are turning. So when we ask what relieves you in the sleep, they say the disc pain goes away. But at the same time, anything which aggravates that particular loading of the facets, loading of the SI joint, or loading on the muscles, though it is relieved in the still position, but whenever they take turning, they tell the typical aggravation of the pain. So they try to lie still in the bed. I would say that.
Okay, so if it's a QL pain, the patient will be lying down in the supine posture, and the turning up to the sides is going to be very painful. If it is iliopsoas, patient will try to, flex and will try to sleep because flexion is going to reduce the pain. If it's a pain, on the one thing which I would like to add on is the greater trochanter bursitis pain. This patient will avoid lying down on that side. So
on the affected side, yes.
On the affected side. So whenever you are taking a history, do ask the patient that if he says, okay, I'm having, pain relief when I'm lying down in the lying position, we need to ask what exactly, which position you acquire in order to get rid of your pain. Fine. Then he said, there is no history of any night pain, right? And then there is a radiation of the pain, and this pain goes to the left hip, anterior thigh, flank, and he's finding it very difficult to wake up from the bed. So Dr. Vaishali, could you please suggest some of the pain generators which are radiating their pain to these particular areas? Anything which comes to your mind?
Yeah, the pain which radiates to the SAIR area, I mean, it's not dermatomal spread, it's a patchy here and there. So one thing it came in my mind is, one is myofascial. Again, facetal pain can also have a referral pain in either posterior buttock or thigh. Same for SI joint also, at the SI joint, and plus it might have at the posterior thigh. And yeah, I could think of these things that can have not radiating, but referred pain to other sites than the actual pain sites. Okay. So myofascial, SI joint, and facet.
Okay, so thank you. So again, it is the same thing which we have been discussing so far. Again, it's SI, facet, or either the myofascial component. Now, I would just go back to Sir. Sir, do you think there is something very important in the history which we need to ask when we are talking about a myofascial pain syndrome? Is there something which we have missed in the history? Sir? Das, sir?
Yes. I was just thinking, you have asked me some difficult question. I was thinking what is its answer. So
anything can be difficult for you, sir.
Yes, see, Google of Pain is saying that to me. I call him Google of Pain.
So whatever you told in the history of present illness, I think almost everything is covered. Have we missed anything?
Okay, well, usually the patient who is having this QL kind of a pain, they will be complaining that they have, their pain will get aggravated when they'll try to take a deep breath. And most of them, you will see that they surely will be complaining of this component because QL is the one which will be attaching to the 12th rib. So this history, usually most of the patients who is having this, they surely be telling this. I think this is the one thing which we have missed in the history. Okay, one more thing which I would like to add on from my side, what he has said, because he has ruled out all the red flags. So now red flags has been ruled out. Second thing, we have taken the history. On the basis of the history, we have formulated, okay, these are the points. What it could be an SI, it could be a facet or a myofascial pain. Fine, 3 things we have made our diagnosis. Now, there is one thing which he has written, that there is no history of breathing difficulty, altered bowel and bladder habit. Now, for this bladder habit, I would really want to add on one point, that whenever a patient who is having the iliopsoas myofascial pain syndrome, they sometimes will give you one history, and sometimes you'll think what he's talking about. He will say that whenever I am constipated and whenever I just pass that bolus of hard fecal matter, then my pain, I'm getting pain in my back. So that time you think that this hard bolus has aggravated, the trigger which was there in the psoas. So do think of this, because sometimes we might think that, oh, this is such a vague symptom. Why are we bothered relating to fecals and this back pain? So that is also one important thing. Second thing, what he has mentioned in the past history, because now we are talking only about the history, is past history when he said that there is no surgical history. So surgical history, how exactly it is important for us as a pain physician is, I would again want to add on one thing there, is like supposedly a person who has met with an accident, and he had, recently my mother had this problem because she had an accident. So if they will put a cast, right, if you have a fracture of your tibia, right, they are putting a cast for you. So what will happen? There will be a difference in your limb length. Okay, so one will be high, one will be lower. So what will happen? The quadratus will be getting contracted on that side and there will be a stretching on the other side. So if this patient after 1 or 2 weeks is complaining of, kind of a back pain, do not think, if all those traumas has been ruled out, you have taken an X-ray, everything has been ruled out. So do think of this again, the myofascial component, because that is also very, very important. Now, other than that, few things which are very, very important when we are just straining our muscles, that also I would like to insist, because this we usually, all of us, we do not even, bother to take care of our body. Like supposedly I'm sitting on the chair, my pen has dropped down, like it has fallen down on the floor. What I'm going to do, I will be just twisting, or I will be stooping, angling my body, try to take that pen. So that time you will be causing a strain to your muscles. So do take care of that. Second thing is, like, when you are getting up from a deep seated chair, when you're trying to get up from that chair, what you will do, you'll be just angling to this side and you'll be just trying to get up. Don't do that. That will also be straining your cores. Third thing, which all of us, we are doing in the morning, when we are just trying to put on our pants, we are in the standing posture, half stoop, one leg inside and the other outside, and we are just struggling. There is so much of imbalance. We are trying to fall and we are just catching hold of the wall or the furniture. So that time also you are just aggravating any strain to your muscles. So if a patient, do ask about these normal things, because these are something very normal. We all have been doing day to day and we don't even know that these are the conditions which will be straining our muscle. So a patient might present to you with something like that, a history he will give, and it will be thinking, this is what we have been doing always, how it is causing a pain. So do think about the muscle straining, because other than your vertebrae, your disc, your nerves, myofascial pain is very, very important, and it is, very much ignored. So I really wanted to stress on these things, and that was the add-on from my side. Okay, so now we are going to the inspection. Dr. Ashok sir has already, insisted such a big thing when it was, when we were discussing about the radicular pain, that do look at the spine, just look for any functional, scoliosis which is there. Now this patient has got that, what Ashok sir was telling us when we were discussing the first case. Now, when you go for the palpation, this person has got a midline tenderness, which is there between L3 and L4 spinous process, which sir has already, explained to us that if we are having any sort of interspinous ligament sprain, this pain will be there. Now he says quadratus lumborum tenderness is positive. Taut bend felt on left side, jump sign is positive. So sir, could you please tell us, because the way we have been examining our facet and the SI, that is not the right way to go for the QL examination. So sir, could you please, brief everyone, whosoever is new, how to go for the palpation of the QL? Because if you are palpating the QL from the back side, it is covered by the thoracolumbar fascia, iliocostalis, and of course the latissimus dorsi. So that window is very small in order to palpate this muscle. So sir, could you please brief us, how are we supposed to palpate the QL?
So palpation means, for bifacial pain, palpation, our fingers should be perpendicular to the muscles which are running. So that means if we are imagining the original insertion, so it is starting from the, the transverse process to L3 and going a little bit oblique. So our muscles should not just horizontal, a little bit up. And also we have to find out what you told, the window, the immediately around the spine is the paraspinal muscles. So the quadratus is lying deep to those paraspinal muscles. So how do we have to go? We have to go a little bit on the lateral side of the paraspinal muscles to find out that window. At the edge of that, we have to have a deep palpations, and our fingers should be lying not just horizontal, a little bit from upside down towards the, making our fingers perpendicular to those muscles. And we have to use the palp of the fingers. This is, the basic things about palpating the any of the myofascial pain. We should be using our palp of the fingers, which will be going, this direction to roll out, to roll the muscle fibers.
So sir wants to say that whenever you are palpating, you're looking for any trigger point, any tender spot on the muscle, the direction of your palpation needs to be perpendicular to the direction of the fibers. That's the reason you need to know how exactly the fibers they are oriented. And second thing, there is one more position which I would really want to add on, because sometimes this is really will be very helpful. You can make the patient lie down in the lateral position. You ask the patient to bring this arm over the head so that it will be resting on the top of the table. And you asked, because he's lying down in the lateral position with the knee flexed off the affected side, obviously you will be palpating. So he will be lying down in a lateral position, and the position which you are going to palpate, that has to be on the top side. Now the knee is going to be flexed. Fine. The knee of the affected leg, whichsoever is up, right? You ask him to take it little back. Now, what are you going to do when you are asking him to bring this, arm over the head and resting on the table? You are just, opening up the thorax. Thoracic cage will go up. And when you are asking him to bring the knee joint little behind the one which is there on the floor, you are, distally, there will be a distal movement of the pelvis. Now you will be getting a very good window. And when you go from the erector spinae to the quadratus, erector spinae consistency is very, elastic kind of, because you have your longissimus, and then you will be going into your quadratus, iliocostalis, and then comes your quadratus. So this consistency will be very elastic. And when you are going inside the quadratus, that is going to be soft. So this is another way you can go for the palpation of the quadratus lumborum. So I will come back to Ashok sir. Ashok sir, what exactly is the position? Because now we have been talking about the myofascial pain syndrome. So there are two very important things we should be knowing. One is to how to palpate the quadratus and how to go about the palpation of the iliopsoas. So could you please brief everyone, how are we supposed to palpate the iliopsoas muscle as well?
Not exactly I'm in the position to tell you. I think pass over this question to somebody else.
Okay. Okay, Das sir, can you tell us?
Psoas is a deep-seated muscle, so it is difficult to palpate the psoas. If there is any special technique to palpate it, I'm not aware of it. But what we normally do it, when we are suspecting about the psoas muscle, then we have to stretch the psoas muscle. Today only we have seen we are suspecting one psoas myofascial pain. So what we need to do is to stretch psoas muscle and to see whether the myofascial pain is elicited. Otherwise, deep palpation just lateral to this paraspinal muscles. First will be coming your quadratus, and then deeper to that is coming the psoas. But what is important is majority of the times palpations of the psoas muscle is difficult because it is a deep muscle. So tender point elicitations or trigger point elicitations for the psoas myofascial pain is always a difficulty. Now, if there is any special technique to palpate it, I'm not aware.
Dr. Kanchan, I just want to add what Dr. Das is saying.
Yes,
I'm not aware, but the thing is the tender point, what we call the trigger points, are almost similar in both this situation. So until unless you differentiate the presentation, it is very difficult often clinically to find out whether it is actually coming from the QL.
Dr. Jordan, what you told is right. Only one thing is it is superficial. So tender point, localization of the tender point to the quadratus is easier. Whereas the psoas is, because it is deep, so you cannot palpate the muscles directly.
Yeah, so you can't say whether these tender points are because of QL or sometimes with the psoas.
So stretching, extension, flexion, and stretching the psoas muscles by extension of the hip joint, by extension of the back and extension of the hip joint. What we normally do is lying down on the bed and extending the hip. You'll be stretching the psoas muscles, and that might be helping us to palpate the muscles. Our abdominal muscles should not be tight, otherwise we will not be able to palpate it. So what we need to do is, patient will be lying supine, the leg will be stretched, and the patient will be having the stretching of the psoas muscles. If the patient is very lean and thin, so anteriorly sometimes we can palpate. Posteriorly, it is always difficult to palpate. So most of the times, this is what is my experience, what is my opinion. The posteriorly, the palpation of the psoas is almost difficult because it is under the cover of the so many muscles. And a very lean and thin muscles with the stretching and extension, anteriorly we can sometimes be able to palpate.
Yeah. Can I add? I mean, I don't know. I'm not sure. But is it possible to palpate the lower part of the psoas or iliopsoas tendon at the level of the ligament?
Yes, yes.
Inguinal ligament
Actually,
or head of the femur?
What sir was telling, like iliopsoas is very difficult to palpate from the posterior aspect. Why we are discussing this? Because we know they are the two very important pain generators whenever we are talking about the myofascial pain syndrome, and it really helps us if we really can find out some amount of trigger. Because if we are just treating only the QL and there is a trigger point in the iliopsoas as well, then it will be a persistent pain, right? So iliopsoas, very rightly said, what sir was telling, it is very difficult to palpate from the posterior aspect, but yes, you can palpate it from the anterior aspect. You palpate the anterior superior iliac spine and to the pubic tubercle, that will be the inguinal ligament. You palpate the femoral artery because that is easily palpable, because we can palpate the distal portion of our iliopsoas, which is getting attached on the lesser trochanter. So there we can just, because the fibers, they are coming like that. So there we can palpate the distal portion of the iliopsoas. If you want to palpate the iliacus muscle, so iliacus muscle, we can go anterior to the anterior superior iliac spine, and there we can look for the iliacus. And if you want to palpate it near the the transverse processes, what you can do, go towards this rectus muscle, and you can do a deep palpation, so that you will be just palpating this against the transverse processes. So it is not there in the posterior, are the way we have been examining, looking for the tenderness, for the facet, for the SI. So QL, you do it in the lateral aspect, right? And if you want to go for an iliopsoas, when you are doing the SLR test of the patient, that time itself just complete the palpation of the iliopsoas as well. Fine.
But I used to say, add on another thing. This is that if the distal part of the psoas is basically tender, those patients are not presenting with the back pain. Those patients will be presenting with the inguinal pain and the hip pain, anterior hip pain. Anterior hip pain, one of the very important differential diagnoses is the tendinopathies of these tendons, the iliopsoas muscles. The back pain, the area of the back pain is more towards the origin and the bulk belly of the psoas muscle, psoas major and minor. So that area is very difficult to palpate. Posteriorly, it's almost impossible. Anteriorly, also only possible only when the patient is very lean and thin. Otherwise, in a little bit of obese, you cannot palpate.
Yes, sir. But still, it's always better to know the position. Supposedly, it happens to be a very lean and thin fellow, so we get the chance to at least palpate. So we should know how to palpate.
But this is the technique what I normally use. I have not read it from any book, just from my common sense of stretching it.
Yes, sir. They do the extension. Yes, sir.
Patient will be lying down. The affected side leg will be hanging from the table so that the psoas is stretched. And now you start palpating. You're in the midline. If you can palpate, sometimes in lean and thin patients, you can palpate the vertebral body also, and go a little bit lateral, you'll be able to palpate the psoas. But that is extremely rare conditions when the patient is lean and thin.
She bowled me actually. She bowled me because in the psoas we see the traction actually. If it is the extension of the hip causing the pain, we consider that definitely psoas is getting tense and patient is having pain. And when acute inflammation in the, as you said rightly, the tendinopathy is there, patient usually very, very painful to palpate near the inguinal ligament or on the medial side of the thigh. It's an indirect way.
But these patients do not present with the back pain. These
they're on the hip pain actually. Hip pain actually.
Hip and the outer aspect of the thigh. Outer aspect of the thigh, they'll be complaining of the pain. So this is what actually I just discussed. It's because this is two important muscles, and we should never, if somebody, we should always be telling, these two important, how to palpate. We can always try, because I always do that. Okay, because whenever I'm doing the SLR, that time itself I go for the palpation. So that really helps. And if we can practice it, maybe, that is good that we develop this habit of, looking for the muscles, because I'm a musculoskeletal person and I'm very fond of the muscles. So I do not leave any muscle which is in that area. Okay. So now.
Kanchan ma'am, one thing I would like to add here.
Yes.
During our MBBS days, we used to have this acute appendicitis differential diagnosis.
Yes.
And there we used to do this type of examination, psoas muscle examination.
Very
And
much
we
right,
used,
Ravi.
yeah.
I still remember my MBBS days. My
Yes.
sir was asking me what else differential diagnosis. I was thinking I have not read. It is only acute appendicitis I used to say. And now later on when I'm into pain, I'm just thinking what exactly was the importance of what they used to discuss during surgery. Very much right, Dr. Ravi. Very much right. So let's come back now to the range of motion. We had lots of discussion on the palpation now. So range of motion, he says flexion is painful, extension is normal, lateral bending is painful, and rotation, he is having pain in the back. So this was already being superbly discussed by Dr. Ashok sir. He has very much nicely explained it, which muscle will have pain when. So we are not again repeating it. And we are just going to the motor examination is perfectly normal. Deep tendon reflexes are perfectly normal. Special test, Faber and Fair is normal, and other test which he has done for the SI is also normal, right? So what we have formulated from our clinical history, and then we have gone to the examination. So initially we had 3 diagnoses in our mind. One was the facet joint, another was the SI, and third was the myofascial pain syndrome. So SI, he could not elicit any, or the piriformis syndrome, but SI, we could not elicit any kind of tenderness there. All the tests were negative. So we are just ruling out, only clinically I'm talking. So we are just ruling out that. Second, he said piriformis. So piriformis also, there was no tenderness, and the FAIR test was also negative. So again, piriformis also we have ruled out. Now coming to the facet, because facet he was not able to localize, right? He could not find the localized tendon because it was very painful. So we are again keeping it as the one of our differential diagnosis. And then I think one thing in the history, which I would really want to ask Tritha, you have mentioned in the past history that he has left SI selective nerve block 6 months back, right? Only there was nothing in the MRI, but there was an S1 Radiculopathy, which was there and proved by NCV and EMG study. So why actually he had gone for that block? I really want to know a little further.
Thank you, ma'am. He visited another hospital that time, and that time that pain was radiating to the leg, up to the great toe, up to the foot, and ECV and EMG, NCV EMG was showing S1 radiculopathy. That's why there some doctor performed S1 selective nerve block and some pain relief for 1.5 months, and again she started having the same problem.
So this MRI was done during the time when he had a selective S1 nerve root block. So MRI was perfectly normal, but still in the NCV and the EMG, they could found a S1 radiculopathy, and he has gone for S1 nerve root block. That's what?
Yes, ma'am.
Okay, fine. So now that's all I think in the history. So now if we have
Dr. Kanchan, just to add, as you were discussing, I'm taking cue from your own point that patient had suffered the S1 radiculopathy and the pain. And that could have been an aggravating factor to the present complaints, because he must have had the protracted gait preventing the stretch of the S1, and that's how he has triggered the pain in the QL now.
I was coming on your own history. That, I was exactly coming to that. So you pulled me out. Fine. Yes, sir.
One more thing, Dr. Kanchan. I wanted to just whether it is possible that these tender points in QL can produce some satellite tender points in minimus.
Yes.
That can give rise to, S1 kind of radiculopathy. That is quite.
It is also there.
Leasing, yes, yeah. So that can be also possibility that he got some vein relief also, na? So that can be because of those, maybe, I don't know, maybe.
Okay. So we are keeping that he can have a myofascial pain. So these are our diagnoses. Facet, if you see 37-year-old, yes, facet degenerative arthropathy, we cannot expect at an age of 37. Inflammatory, even if we are expecting everything, the inflammatory markers are normal, but still we are keeping it as one of our diagnoses. Okay. Though, sometimes the inflammatory markers are negative, but still the patient can have, and we can only rule out with the diagnostic block of the facet joint. So our provisional diagnosis is, first one is the myofascial pain syndrome of QL. Then second, what Sir was also telling actually, so we can just intermingle these two. So maybe it was the S1 Radiculopathy. He has gone under, there was an abnormal, gait, and which has activated the trigger points which were there in the QL. So that could be the reason. There could be a satellite, which is there on the gluteus medius, and that would have got, messed up, and he is now ending up in this. So now we have formulated our clinical diagnosis. Now, what is the second step which we want to go? Is there something, a role of, whenever we are talking about a myofascial pain syndrome, I will come to you, Dr. Archana. Is there any other, the metabolic markers which we should be going for, though there are no clinical correlation of those, but is there some metabolic markers which we should be including whenever we are treating a patient of myofascial pain syndrome? These are the certain investigations which we need to go for. You are muted.
See, basically this trigger point formation is because of acetylcholine and all those end plate noise. So there is always a ischemia, taut bands, and there is a release of all those, substance P vasoactive things. So I would always think that these patients, like they have to kind of, undergo what you said. What was the question you said?
Actually, there are certain kind of, metabolic markers like TSH, vitamin D, iron.
Yeah, I mean, so we have to rule out the factors which, I didn't get the question actually.
Okay, there are certain metabolic markers.
I was thinking about these markers, there
are certain, metabolic markers, like metabolic markers.
So
like
vitamin D, calcium, basically vitamin B12, basically. Thyroid hormones, that is important to rule out.
Yes, that's all. So what Dr. Archana is telling, we need to go for a TSH. We need to go for your vitamin D, vitamin B12, and do whenever person is coming to you, because nowadays the hypertension, even it is coming at an earlier stage. So this hypertensive patients may be on statins, and that could be a reason for the myalgia which he is getting, So we need to rule out that also. So these markers, though there is no experimental correlation with these markers, but still we need to order, because there is a correlation, clinical correlation, which they have seen, though there are no experimental studies which they have proved that there is a direct correlation between these markers and the myofascial pain.
These are one of the risk factors, actually. Nutritional deficiencies are one of the risk factors to.
But there is no correlation.
Yeah.
Okay, so how we have now, ordered the investigations also. And now if we want to go for the confirmation, so how are we supposed to confirm? So I'll come back to Sir again. So Sir, how are we supposed to confirm the myofascial pain syndromes?
So the myofascial pain syndrome diagnosis is mostly clinical. So sometimes in ultrasound, some taut muscles, but again, difficult most of the times. This taut bands, taut muscles, not very difficult to situation. So if you can relax the muscle, so if you are looking about the basic pathology, that there is a tightness of the muscle. So if you can relax the muscle, and if the pain is immediately relieved, that is how we can do it. So this is mostly done by trigger point injection. Though for the diagnostic purpose, trigger point injection can be done by so many ways: manual nebulization, dry needling, so many things. But for the diagnostic purpose, the best way of making a diagnosis is local anesthetic in the muscle to relax it and see whether the pain is relieved or not. This is by the for the diagnostic purpose. Therapeutic purpose, somebody may not give the local anesthetic. Somebody may be doing the other things as well. Somebody can do the, even the muscle plane block also. So all those things can be done for the therapeutic. But diagnostically, local anesthetic, that too concentration should be 1.5% of lidocaine or more than that to relax the muscles immediately and see how much relief is there.
Okay, sir. Thank you, sir. So if we want to diagnose, if we want to confirm our diagnosis, we need to go for a local injection into the trigger point, and then pain should go off. This is how we are going to confirm our diagnosis. Now, second things, Dr. Archana, is there any role of, these physical therapies or drying? Is there any role of any physical therapies or non-interventional modalities in treating this myofascial pain syndrome?
Definitely, they have a very big role. I would say that's a very important thing. Physical therapy, you mean exercise point of view, different kinds of exercise, flexion exercises, extension exercises, and there is a vast role. I wouldn't say a physiotherapist. We should, as a clinician, should be talking to the physiotherapist whenever we are actually giving the patient sessions of exercises, and which exercises needed at what particular for what particular pain or muscle. And as far as I know, I do give dry needling sessions. Very often I do give dry needling sessions. After confirming that it is myofascial, I first palpate and then actually find out the trigger points, myofascial trigger points in those muscles. I mark them and I do dry needling at the interval of 1 or 2 days, and I give say 5 sessions sometimes, depending on the condition and patient's availability. I do increase the number of sessions and the number of needles and the depth to which I give. I generally try to elicit that local twitch response. I always look out whenever I'm doing dry needling. I look out for that response to be more effective when you're giving dry needling. So I always give dry needling to the patients along with, and after that, I actually give the physical therapy. That is how actually when the muscles is relaxed, physical therapy works better is my experience.
Okay, Dr. Matthew, would you like to add on something from your experience of this myofascial pain syndrome? Would you like to add on something on this?
Okay, thank you. I admit that I don't go into such a detailed assessment of the muscles because I do make those markings, as Dr. Archana said, those trigger points markings. But when it is more lateral than the erector spinae margins, like in the QL, as you mentioned, or I usually regard them as, I don't know whether it's correct or not, as referred pains from axial structure. Okay, that's about all I have to offer. Thanks.
Okay, so Dr. Matthew wants to say that the trigger point in the QL and your other paraspinal muscles, there could be secondary myofascial, pain syndrome, not the primary one. Fine. Dr. Jeshnu, would you like to add on something on it?
Muscle relaxants would be quite useful in such patients, ma'am. Apart from physical therapy like stretching on all those things. So I preferably would go for muscle relaxants and stretching exercises by a specialist physiotherapist for the
analgesics, of course. Analgesics, muscle relaxants, and stretching.
Yes. Okay, Dr. Vaishali. Okay,
I guess most of the patients are. Yeah, please, ma'am. Over to you.
No. There was some problem in my connectivity. I could not hear.
I think with this analgesic, muscle relaxant, and stretching exercises, and sometimes TENS or something like some electrotherapies are useful for most of these patients. And then if these are not responding, then we can think of next step of interventions.
Okay, so Dr. Jeshnu wants to say that we should go for analgesics, we should go for muscle relaxants, and we should also go for the TENS therapy. And if patient is not responding to them, we can go for the other modalities of treatment. Okay, Dr. Vaishali, would you like to add on something?
Yeah, I definitely agree with Dr. Matthew because we need to rule out whether it's primary or secondary. Primary myofascial pain, yeah, muscle relaxants, analgesics and stretching will help. But before that, definitely what is causing the myofascial pain? Because any trigger point or any muscular tightness or spasm may be because of the underlying pathology of the underlying structures. Like it could be because of the facetal arthropathy also. Or because as you only said, because it may be secondary to the other conditions, like if he had restrictions of movement because of the fractured limb or anything. So that also can be a secondary cause according to me. But yeah, facetal arthropathy is one of the or any other condition which can lead to secondary myofascial pain. So that should be ruled out.
Okay. So
Yes. This is very, very important. I just would be adding 2-3 very interesting case in my practicing life where there was myofascial pain and the underlying cause was very dangerous. One I can remember here in the audience as looking about the Palak chapter. So I can remember when she was doing fellowship here. One time I was not in our clinic. So she saw one patient and she gave me a call that, sir, I got a myofascial pain, trapezius, typical trigger point and everything is there. So shall I go for the trigger point injection? I told her, is there no other features? Patient was presenting with the neck pain radiating up to the shoulder, very severe pain, and there was myofascial pain. No other clinical features suggestive of anything. So she told, okay, no, there is no other MRI or something was not there. I told, okay, don't prick the needle, unless you are having the cervical spine MRI. And then he was having an MRI and noticed a very big prolapse, very big prolapse. Another thing I can remember, there was some myofascial pain, and patient was that was in the upper back, mid back, and the patient was ultimately proved to be a CLR. So these are just two hot came in my mind. But what I always tell that whenever you are getting a patient which is classically myofascial pain with a jump sign, with a stretching positive, you have to rule out the primary cause if it is there anything, and then only you should think of the trigger point injection. Don't go for any interventions unless you are ruling out any primary causes there. If it is primary myofascial pain syndrome, definitely you have to go for the trigger point injections or other things. But if it is not, if it is secondary, primary cause definitely can be dangerous and that must be treated. But sometimes this is also true that primary cause sometimes is healed by itself. Primary cause is taken care by the surgery or other treatment, and the myofascial pain might be lasting, might be going ahead. It is propagating as a primary disease. Sometimes this can also happen, that the primary condition has healed and the secondary myofascial pain has now converted into a primary myofascial pain. That is also a possibility.
Okay, Dr. Ravi, would you like to add on something?
Kanchan, there was some raising of hand I saw. You can ask. I don't know whether now
okay, Dr. Anand want to ask something, because this patient had S1 type of a radiculopathy. So I think Dr. Archana, would you please answer that question about the satellite TRPs, which you were talking, because that presentation will be like sciatica and we call that as pseudo sciatica, right? Where the presentation will be typically, if you have a satellite lesion, you are going to have a presentation of S1 radiculopathy, and that's what this patient really had. So Dr. Archana, could you please tell us about that satellite lesion?
Dr. Archana, unmute yourself.
When I read this history, that thought came into my mind that this looks QL, why this S1 is confusing. And this thought came to my mind, this can be satellite. It is very common when it is a primary myofascial. Many a times there are satellite myofascial trigger points created due to the primary in the nearby areas. And it is found that if you do distal dry needling, even the proximal pain reduces, or other way around also. So in this case, probably that S1, he got pain relief. Maybe this, I don't know why he really got relief for 1 month, but that was confusing factor. But satellite satellite trigger points are very difficult to find out. Sometimes there is a radiation, the patient may give you history which is confusing, that I have pain in the calf, I have pain in the back of the thigh, or I have pain somewhere else which is not related to quadratus lumborum also. And sometimes even in the abdominal area, they can, give that there is pain. So this is, whenever this is confusing, we just try to look for these satellite areas, or secondary, they call it secondary. And sometimes they are not active. They are in the latent phase. I mean, they're not producing pain, but if you relieve, pain of the primary, sometimes these get activated, and then again, a different type of pain the patient complains of. So they give that confusing picture sometimes, this satellite trigger points. Just keep it in, we should keep it in mind.
Yes, Dr. Anant, you wanted to say something? You have been raising your hand.
Yes, madam. We are considering the satellite problems, as madam said. Sir, how much we can ignore the NCV studies in this case? Do you recommend to repeat the NCV studies, because NCV is a quite good evidence of radiculopathy?
Actually, if there is a satellite lesion, what I would suggest is you block your gluteus medius. Okay, if I'm not wrong, not gluteus
minimus.
Okay,
Minimus.
block the gluteus minimus. This pain will go off.
Yes.
Right. So before ordering an NCV, if you're expecting it to be a myofascial pain syndrome of your quadratus, you just give a local in the gluteus minimus and it will go off, right? And then it will reoccur after some time, right? Because your primary is there. This is what I would suggest you if you're expecting clinically to be a quadratus lumborum. It's better to go like that. But
no, Kanchan, what Anand is telling, that
how
what
much
is the in this scenario, what is the significance of the S1 radiculopathy which came in the EMG NCV? And second important thing is MRI was normal. So how to correlate with this? So this was the question by the Anand. Am I right?
Yes, sir. Yes, sir. That's
so
what I
want to tell, that this S1 radiculopathy features is not because of the S1 nerve root compression always. That means the most commonly S1 radiculopathy is seen because of the nerve root compression, but it can also be coming positive if there is a, like I have seen several cases of the piriformis, the quadratus, this kind of myofascial pain, which can compress the lumbosacral plexus, can also cause the S1 radiculopathy in the EMG NCV studies. That means it is not specific that it is the nerve root always. So now, retrospectively, if we are talking, why giving S1 nerve root block gave around 1.5 years relief? So my assumption, again, it is an assumption only, it cannot be proved, that when we are giving any local anesthetic steroid or something in the foramen, whether it is a L5 or S1, it actually spreads along that neurovascular bundle. So now that means if you are giving it into the S1 foramen, that is spreading into the lumbosacral plexus. So now it will be spreading proximally as well. Now the proximally, what is there? Anteriorly or psoas, posteriorly is your QL. So that means it may be myofascial pain, which was picked up by the EMG NCV study as an S1 radiculopathy, but actually it was a primary myofascial pain. This is a possibility. Or another remote possibility is it was an S1 radiculopathy, which was where the radiculopathy was spontaneously resolved, because if you are looking about the studies also, sometimes prolapse disc can be automatically resolved. So S1 radiculopathy was there initially, secondary myofascial pain was there, and now the prolapse disc was resolved, and now what is present here now is the myofascial pain. So both of this is a possibility. And if you are giving local anesthetic to that neurovascular plane, it is not only blocking the nerve root, it is also relaxing it is basically a plane block, fascial block. It is going into between the two muscle layer, and it will be taking care of that pain of either my psoas or quadratus, whatever might be.
Then one last question, sir. Do you repeat the NCV studies? If at all.
Normally, this NCV is not that specifically telling about the radicular pain. So that is the reason why I am not in favor of the repeating the NCV studies. And at least in my patient, I have seen NCV studies are not that pleasant experience for the patients. So many patients I have seen complaining, sir, what tests have you done? They are pricking needle, they are giving shock. So so what I feel is it is not that so important to make a diagnosis of the radiculopathy. So why should we go for it repeatedly?
And patient has to pay, sir, for every investigation you advise. So,
Dr. Anant, I would like to add here one thing. So if you are thinking of especially S1 radiculopathy via NCV, it is very less specific. You have to go for needle EMG. needle EMG targeted via the S1 nerve root. Okay, and as like Das sir told here, there might be extra spinal compression that may give you false positive result with the NCV.
It is very
so
common.
that is quite
Very
true.
common.
That is quite true and very common. So you must take this point into consideration. The extra spinal compression, their MRI might be normal. Means no nerve compression at the disc level. Okay, but nerve compression via this piriformis or this upper psoas, the lumbar plexus, the whole lumbosacral plexus is deep to psoas muscle. So you can think of it. Okay.
Yes. I was thinking like there might be a lesion distal to the nerve root. That is quite possible.
Right.
Whatever
Right.
may be the reason.
Right.
Okay.
So NCV in this case was really, telling us something, but we missed the primary one, I think, right? So that is a good thing that, when you are taking an image, we should always be correlating it with our clinical diagnosis, with our examination. And since this patient had an MRI also, so that was really be helping to rule out for the proximal lesions. So I think if any one of you has anything to say or you want to ask us.
I'll be asking Jayashriti's opinion also. Jayashriti, if you can tell something about this one, particularly about the S1 radiculopathy, which is coming over the EMG NCV studies and MRI is normal. So what are these possibilities? When this can we can see?
See, with SI joint, as far as investigations go, there is not much to add. The only one point that I felt with the history of the pain going away, lying down, exacerbated, one thing we also have to consider is lumbar spinal stenosis. So when you do get an MRI, I would say it is good to have the radiologist comment on the pedicles and the canal measurement. So you will know whether it is one area that they have stenosis or others. As far as SI joint pain or anything specifically done for SI joint, what I would say is look in 40s and 50s, depending on the type of work the patients do, you may have both. So sometimes it is hard to just say that it is just a disc or just a muscle spasm or just tenderness over SI joint. So if you're waiting on any imaging, you feel that your Patrick's Faber's is positive, then it's outside the spine. You don't lose anything. You can do a diagnostic injection of the SI joint. That would be my approach to SI joint. Or ruling out others when you also have midline pain or pain in the back.
Thank you, ma'am. So Dr. Ashok sir, do you want to add on something?
Yeah, I just wanted to actually sum up things like what Dr. Das has mentioned or Dr. Tong has mentioned, that there is always a possibility of primary myofascial pain also, because in our clinical settings, history often suggests. I can give 2 or 3 examples when somebody took a sudden episode of doing dancing for hours. I have seen that. Somebody have taken the badminton championship without practicing or warming up properly. Somebody played basketball for 2 hours. So these 3 situations, and also somebody have undergone the TKR, which is failed. And these are the situations.
Another common thing I used to add, somebody was sitting in front of the air conditions. The air conditions cold air is putting it. Yes, I have seen cases on the back, putting in the continuously back, and then there was the myofascial pain.
I had this, sir.
So yes, rightly said, sir. Absolutely rightly. So primary lesion is there. So it's not always secondary. We should look for the secondary causes, but it is primarily also. Another
I forgot to mention that there is something you are trying to stretch your hand, you are trying to pick up.
Yes,
so you're stretching beyond your capacity. So that also can cause the.
Dr. Kanchan was also already mentioning that taking the pen without properly bending and can cause the stretch of the QL. And now coming to the needling part, what Dr. Archana was mentioning, dry needling. I have seen Dr. Lakshmi was doing this dry needling under ultrasound, and very beautifully she showed that a dry needle, when put into a normal muscle fiber, how it behaves, and then when it is put in the taut fibers or the trigger point, how it behaves. It actually dances, and she called this a dancing muscle or dancing noodle. You can see very well under the ultrasound. So just to mention, when we are doing dry needling, and though Dr. Das has mentioned, it is not always be specific to locate those taut muscles under the ultrasound, but if by chance if you get it and you put dry needle, definitely you be sure that what we call it is a twitch sign. When we see this twitch sign on the ultrasound, it is really a dancing muscle, which really confirms that your needle placement is right.
Yes, sir. I have seen that dancing with her. Yes, sir.
Yes, it is.
I
It
had
is
a
also.
paper
It is also visible with the naked eye also. If
Yes,
you're
yes,
putting the
it is
needle
very much visible.
above your right trigger point, your needle will be jumping, dancing.
Yes, yes. I had a paper, sir, in IJP on this only, back pain, dry needling. 40 patients I had done. So I had got very good results, sir.
I have just highlighted your work, Dr. Archana.
Oh, yes. Thank you, sir. Thank you so much. You are always motivating juniors like us.
So I think Ashok sir has already summed up everything. So anything else anybody wants to add on?
Some raised hands are there. Ask them to.
One risk factors, in risk factors, I would like to add, this long travels on bad roads or on two-wheelers. Also, they get these myofascial kind of pain. So, and the mattress which they use, that is also another thing. And chronic stress conditions, especially adds to quadratus lumborum. I have seen lot of patients are having this stressful anxiety and depression or some other problem in their family or something. There is a lot of exaggeration in their pain. Actually, that's what I wanted to add. That's it.
Dr. Sahina, you want to ask something?
Do not forget camel ride.
Yeah.
Yes, ma'am. I was keeping quiet. I was thinking Joyshri madam is having very severe headache. So today, how is your headache now, ma'am? Is it fine?
My headache will get better once we lose. Sri Lanka loses a few wickets.
Okay. So I will pray to God that Sri Lanka loses this match today. Okay, ma'am. Dr. Sahina wanted to say something. Dr. Sahina?
Yes, ma'am. I just want to ask, ma'am, I just want to know, ma'am, in case of NCV and EMG, patients have S1 Radiculopathy, but MRI is normal. So can we just tell it's a case of neuropraxia, ma'am? Just simply say neuropraxia.
We had this discussion. Sir has explained this. Sir has already...
Yeah, ma'am. In last case,
the basic information is neuropathy extraspinal. After the nerves has left the spine, and then there is a neuropathy because of the compression or because of the anything, then we might be getting this kind of things.
Yes, sir. So can we simply say it is the case of neuropraxia in S1 nerve root?
But there is no history of... But there is no history of any neuropraxia, means there must be some trauma, some stretching. There is no such history.
Sir, extraspinal compression can cause the neuropraxia as well, sir.
That is what I'm telling, but that is, mostly we call it as a, rather than we calling it as a neuropraxia, because neuropraxia, there will be, what will happen? There is a temporary conduction loss. So that is not really going to produce the pain. So now the entrapment is a better term, and myofascial pain is a better term rather than the neuropraxia.
Oh, yes, sir. Thank you, sir. Sir, another question I just want to know, sir, the most common complaint patients, actually female patients, they have after LUCS, I mean, seizure section, sir, after 2 to 3 years after the seizure section patient, common problem is there is back pain. So what's actually the reason behind this, sir? And what we have to do for this condition?
So cesarean section, again, this is one of the very common patients blames us, patient comes us that, okay, spinal anesthesia was given and my pain has started. But mostly there is no relation with the spinal anesthesia because the prevalence of the back pain, if in the normal delivery versus cesarean section are almost similar. That means when the baby is hanging, the pulling of the structures and that can cause the back pain. Incidence is almost around 10 to 12% or something like that. Exactly, I can't recall. So it is similar to that, even if the patient is having the normal delivery. And the delivery, that means pregnancy is one of the common areas. At least 1 in 10 patients, the patient presents with the back pain later on. So
yeah, I would like to add, sir, one thing.
Yes, yes.
It is because in pregnancy, the anterior abdominal muscles, they completely lose the tone. So the whole pressure goes on to the back muscles. So, and then this continues. If you tone up your muscles immediately post pregnancy, then the back pain will never be doing. But generally, it doesn't happen. But a new mother, she's never free to do that exercise, and this back pain. Within 1 year, back pain sets it and chronicity. I myself have experienced that severe back pain.
So it is very common and mostly is musculoskeletal, muscle and later on facet, sometimes SI joint. SI joint is also common during the pregnancy, particularly after the normal delivery. So these are common and
so sir, it's our completely misconception that is related to the subarachnoid block, right, sir?
The
so it can be happen without
incidence of this back pain after subarachnoid block or without subarachnoid block, incidence are similar, which clearly indicates that these are not related with the subarachnoid block. These are related with this what Dr. Archana just now told, that it is because of the pulling of the muscles and the other structures of the back patient is having back pain.
Thank you so much, sir.
So
And
Dr.
Madam,
Saina, just to sum up what the expert have said, this pain is because of the deconditioning of the abdominal muscles, overloading of the back muscles, and as you also asked for the answer, is doing the exercise, proper strengthening of the abdominal muscles and taking away the load from the back. So this is the answer for this. And as Dr. Das very aptly said, it is not related to your spinal, which often patient correlate that it is after spinal.
I have seen so many patients. They are blaming after that, the spinal anesthesia, then they have started the back pain. This is so common.
But I want to add, sir, if you ask, most of the time it is not the patient, but it is their relative who is suffering with the spinal pain.
That is also true. That is also true. So you have to explain. Normally, I explain in this way. I told that the incidence of the normal delivery and then back pain and the spinal anesthesia and then back pain almost similar in incidences. So basically, we cannot blame that this is because of the spinal anesthesia.
And you guys are all sitting in India. So the common exercise, which you can even do standing up, will be called Agni Sara. So all of you go and find out how to do it properly.
Agni Sara. So today only I'm going to search it, ma'am. Surely. Okay. So let me summarize today's discussion on our myofascial pain syndrome. So myofascial pain syndrome, we can have two types. One is primary and secondary. Do not always think of secondary because primary itself is there. Okay. Second thing, we have to be very careful with the mechanics of our body. Do take care of your spine. Avoid all the unnecessarily stretching or unnecessarily loading your spine, because that is going to result in this primary myofascial pain syndrome. And there are certain risk factors which we should be taking care. One is your TSH, then is your vitamin D, statins, and vitamin B12. It is a purely clinical diagnosis and based on the history and the clinical examination. But if you really want to confirm the myofascial pain syndrome, you need to go for a diagnostic block of the trigger point. Fine. Yes, physical therapy, they play a very important role. So we need to advise the patient, the rehab, the stretching exercises, and there are other modalities of the conservative treatment as well. And if the patient is not responding to that, we can go for the local with the steroid injection in the trigger point. So that's all for the myofascial pain syndrome. That was the diagnosis of today's patient. And in the end, I would really like to say, do not get carried away by the images. Please be very strong in your clinical history and examination, because sometimes your image findings, sometimes your the reports given by the person, it can go wrong. But if you are very good in your history and your examination, believe me, there is no shortcut to that. So with that, I would really like to thank all the panelists, and especially I would like to thank Sir for having this webinar, so that we can exchange ideas and we can share knowledge from each other, like as with the other, as the audiences. I too have learned so many things from all the experts today. So thank you so much to all the experts for taking out their time and for giving their valuable time to Dardia. So thank you for spreading the knowledge and happiness among all. Thank you from the bottom of our heart.
And thank you, Kanchan, for very nice discussions, moderations of the topic, as well as Karthik as usual. I don't know if Karthik is there or not, or already left.
Thank you. Thank you.
Yes, Karthik, are you there?
Thank you, sir. Thank you.
Okay, thank you, Karthik. Very nice discussion by you and Dr. Kanchan. So this case discussion will be going on every Saturday, and I'll be asking all to participate, and not just listener. You can raise your hand, you can put your questions in the chat box, you can ask the questions directly, you can comment, you can add the things and make it more interesting. So see you.
Very well done, Kanchan and Karthik, as usual. And thank you, Gautam.
Thank you so much.
Thank you, Jasmine, for joining.
And take
Thank
care
you
of your
all
headache.
experts.
Thank you, sir. Thank you very much. Thank you, Kanchan. Thank you very much. Thank you, sir.
Thank you.
Thank you,
Thank you
Karthik.
all.
Thank you, sir.
Thank you
And
so
thank you,
much.
ma'am.
Thank you.
sir.
Thank you, Dr.
Thank-
Matthew. So join us next Saturday at 5.
Thank you.
Thank you.